the slides. Okay. All right. Um, okay. So my talk today is novel approaches to addressing stigma as a barrier to healthcare among Black sexually diverse men. And the first thing I want to do is, of course, acknowledge some individuals and entities who have helped out my team's research along the way. Of course, the thousands of participants who volunteered their time in joining our studies, the community-based organizations providing direct services to participants who we've worked with throughout who I've worked with throughout the beginning of my career, the policy-based organizations working to impact systemic change. So I always think of my research as like one small piece of a much larger puzzle, and we're kind of all in it together. And so I'm very grateful for the work that multiple agencies do, my collaborators and my co-authors. My work has been continuously funded by the National Institutes of Health, so I'm very grateful for that level of support, and I have no disclosures to make. Okay, so quick overview of my talk. I'm just going to say a little bit on data on HIV incidence and prevalence among Black sexually diverse men, although I'm assuming that most of you are familiar with those data. So I'm going to kind of speak specifically to data that we've collected on HIV prevalence, data that my team has collected on HIV prevalence over the years. And then an overview of stigma-related considerations, kind of the different things that we process before going into intervention development, or what's kind of led up to the phases of intervention development that we've partaken in. I feel like many people find stigma to be kind of a very challenging concept to take on because it's so massive and it's kind of, its tentacles reach very far. And then different interventions that we've developed to specifically focus on stigma and address that gap between advances being made in HIV prevention, but then an individual's ability to actually access those advances that are being made in HIV prevention, and then some future plans. Okay, so one of the many reasons why I focused on HIV prevention, particularly in the Southern US, particularly among race and sexual orientation diverse groups, is because in our own research, we see very high rates of HIV transmission, and these rates of HIV transmission have really persisted over the past 10, 15 years that I've been doing this work. So we kind of fairly consistently see in our sampling research that about 35% of individuals will report living with HIV. And then when we follow people who test negative, about 5% will test positive for HIV over the course of a year. So of course, those are very alarming rates of HIV transmission. And again, we're primarily working out of Atlanta, but then years ago, I started in Atlanta, then kind of moved out broader throughout the state of Georgia. And then now we're also working in neighboring states as well. Alabama, North Carolina, South Carolina, Florida, Tennessee, but primarily through the Southeastern US. So what exactly is going on? Why do we see these rates? And there's a lot of different angles that you can process to kind of get at why we see increased HIV prevalence rates among certain groups. And healthcare inequities, of course, is a huge driver of health disparities related to the epidemic. And there's many different ways in which we could take on these healthcare inequities. But the specific area that I've focused on is that of stigma. And there are a lot of examples of stigma impacting healthcare access in the literature. Some of the examples that I've kind of like hung on to, that I've kind of framed my research around, is the our biases in our race-related biases in prescribing PrEP, also in the biases that we see that are related to medical mistrust between patient-provider interactions. And when we look at how the HIV continuum of care has played out, of course, HIV testing or awareness of the need to routinely test for HIV is something that has kind of somewhat fallen short. And so most of my work has specifically focused on stigma and focused or specific to stigma accessing HIV testing, that first step in the HIV care cascade. Something that has not necessarily changed over the years is our need to move from focusing on urban populations to also including urban populations as well. So when I first started this research about 10 to 15 years ago, a lot of the interventions were really focused in urban clinics. And as things kind of progressed over time, we saw the need to really reach out beyond areas where HIV prevention services were concentrated into communities where it might be an hour or two drive in order to access HIV prevention or HIV treatment services. So what you'll see as a theme throughout the interventions that I'm going to present on is that we do try, and then particularly in the context of COVID, that kind of accelerated the need to move things into a mobile manner. So what you'll see in the interventions that I present on is this real mix of trying to access individuals who logistically are closer to HIV prevention and treatment services, but then also those who have greater logistical barriers to accessing care. So that's a real strong priority of the work that my team and I have done. Okay. So there are a few different perspectives to take on stigma, and I'm just going to walk you through how I perceive stigma and how my team has approached the different aspects of stigma. And there's different definitions of it. Like historically, it's, one of the most common definitions of it that you see is Goffman's definition, and this is from 1963. And you still kind of repeatedly see this in the literature, that it's an attribute that is deeply discredited by society and results in rejection. And there's also some really interesting facets of stigma that I think are important to consider. One of which is that all societies will stigmatize some conditions and some behaviors because doing so provides for group solidarity by delineating outsiders from insiders. It's a process where we label, stereotype, disconnect, engage in status loss, and discriminate. What's interesting about stigma and where things become complicated is that it's really, and this goes down, my roots are as a social psychologist. So this kind of like speaks to my graduate student days where we learn that human behavior, it is human behavior to want to create in-groups and out-groups. Because creating in-groups and out-groups creates a sense of like, I belong to one group, this group is important to my identity, this group is important to my well-being, and that's different from these other groups that I don't identify with. However, when you do that, in order to create in-groups and out-groups, you engage in this process of stigmatizing. You engage in the process of status loss, potentially, because groups tend to form hierarchies as well. The issue of stigma in this context, or the issue of status loss in this context, is that in some cases, when you create in-groups and out-groups, that has an actual measurable effect on health outcomes, say in the case of HIV prevention and treatment-related health outcomes. It doesn't always have that type of status loss associated with it, but the process that we engage in to form in-groups and out-groups is the process of stigmatization. It's just that in some instances, that results in real measurable negative effects. And kind of more specifically, this is work, so Val Earnshaw is a good colleague at University of Delaware, and her work has really helped inform my how I approach my intervention development and to address stigma. And so what Val is kind of like neatly put together and what I've kind of adapted over the years is this HIV stigma framework model. And basically what Val's model gets at that I've adapted is that there are these drivers of stigma, which are stereotypes or group-based beliefs about individuals, and prejudice, which are negative emotions about individuals, and discrimination, which is the expression of prejudice and stereotypes. These are the things that drive stigma, that drive the environment wherein stigma occurs. And then there are also the mechanisms of stigma, the things that people experience. So that would be internalized stigma. So it's the internalization of these stereotypes, prejudice, or discrimination. Enacted stigma, so that's actually experiencing stigma. And then the anticipation, that potential, how the potential of being mistreated impacts behavior. So she kind of like very nicely brings in these drivers and mechanisms into one model or framework, as she says, and how those things can come together and impact health outcomes. What's so very helpful about looking at these drivers and mechanisms is that you can actually start doing intervention development around these items, and of course, and then you can start to kind of process how to develop buffers against these things and how to like really understand the emotional impact of stigma. So this model has been particularly helpful in developing my work. In addition to the measure or the model, or I should say the framework that Val Earnshaw puts forth, we also developed this concept of microaggressions. So of course, microaggressions have been around in the literature for many, many years. We developed a scale that was specific to HIV-related microaggressions. And basically, how we see this, and the reason why we did this is that, so microaggressions would be considered a form of enacted stigma. So it's kind of like a subcategory under enacted stigma. And the reason why we developed the perpetuated microaggression scale was because we found that a lot of the measures of stigma were assessing big things, big upheaval things, such as being fired from one's job or being kicked out of one's house, experiencing physical assault. And among our participants, we were seeing those items somewhat infrequently reported. Now, what's interesting about that is that doesn't mean that those, of course, those things have the potential to be hugely impactful. But the feedback that we were getting from individuals, and we've seen this in other literature, of course, is that it's like the daily hassles that individuals experience as a result of living with HIV. So we developed a couple of scales that look at experiences of HIV-related microaggressions and perpetuating HIV-related microaggressions. So it's kind of like a little bit of an add-on to that framework that Val had developed. And then we also look at these two additional concepts. One is called stigma by association. And in the context of stigma by association, what's really interesting to look at is kind of the progression of PrEP, or pre-exposure prophylaxis, for HIV prevention, which is a big, that's a kind of a major outcome that we look at in the intervention development research that we do. So, but particularly in the days when PrEP was initially approved, kind of in the beginning, there was this association with PrEP being a drug, of course, to treat HIV. And there were a lot of concerns about individuals not wanting to take PrEP because it's associated with living with HIV. And how would they explain that to their partner? How would they explain that to their family if those individuals were to see this? So there's this interesting kind of stigma by association that's played out in the HIV prevention and experiences related to HIV prevention and the literature around that. And then in addition, there's also this concept of stigma and transition. And so that's basically the study of individuals gaining an identity that is considered stigmatized. And we do see that in the case of HIV prevention and treatment process as people test positive. So in addition to that initial model, that our framework that I showed you of VALS, it's focused on drivers and mechanisms. We also focus very specifically on microaggressions, stigma by association, and stigma and transition. And also, I tried to say this in, every time I have an opportunity to kind of talk in a broader sense about the work I do, I always think it's just important to kind of think about how different public health approaches and if this is of interest to somebody, I'm happy to talk about this more. Kind of being mindful of stigmatizing processes within public health approaches. So one thing, and I think that, I think this has been well established in the literature, but just how we describe populations that are quote unquote hard to reach or hidden is just a real mischaracterization of what's occurring. And it's not lost on me that the article that I showed just a few slides back was America's hidden HIV epidemic. It's this majority perspective on a minoritized population and being just very conscientious of the potential impact of that is critical. One specific example of this that I kind of see come up with participants time and time again in our qualitative work is the messaging around U equals U. So the untransmittable equals undetectable, or I should say undetectable equals untransmittable. Some of the feedback that we've gotten over time is that not all people living with HIV necessarily have access to treatment needed for an undetectable viral load or will reach viral suppression. So thinking through some of the potential consequences, unintended consequences of that messaging is really critical. This is also something to be mindful of that we have also seen in our quantitative research on stigma that I was kind of, I was a bit floored when we saw this. So we have a scale of, it's called an HIV risk perception scale, but it's basically like one's perspective on the likelihood that they will test positive for HIV over their lifetime. I'm just going to show you some example items from this. So one item is I worry about getting infected with HIV. And 31% of the samples said some of the time, 16% of the samples said a moderate amount of time, 10% said a lot of the time, and 17% said all of the time. Getting HIV is something that I'm moderately concerned about, was 34%. Concerned about a lot was 17%, or extremely concerned about was 27%. So what this scale really, the reason why this scale stood out to myself and my team was because it does appear that the messaging about the potential for HIV transmission is very strong and very impactful. And it does give me at least pause in thinking about how we're framing things and the potential for this concern about HIV transmission potentially getting in the way of other more positive, potentially more positive messages around HIV prevention and positive sexuality. So it's given me a lot to think about how this scale is unfolded. And it also has the potential for serious consequences. So when we look at the self-perception of HIV risk, you might think that this translates to motivators for learning one's status or for being in healthcare, but it actually has the opposite effect. As you kind of sensitize people to being concerned about HIV transmission and increase those self-perceptions of HIV risk, that actually results through multiple mediation through depression and HIV status avoidance, greater time since last HIV test. So as we increase self-perception of HIV risk, we also increase the amount of time since someone's last HIV test. And we see something similar when we look at that same model in time since last routine medical exam. So as increased risk for HIV increases, so does time since last routine medical exam. Okay, so stigma is defined, stigma avenues are understood, stigma is operationalized, but now what? So one of the things that comes up a lot, one of the things I try to prioritize when I'm mentoring students is that taking on addressing stigma can be very overwhelming because it impacts so many facets of life, and it's very all-encompassing. And at this point, the way I see trying to manage stigma, and there's a lot of different ways that this can be done, and I'm going to talk about some different levels that can be intervened upon. But what I try to stress to people is that it can feel overwhelming. But what's important to remember, I think, is that like we're all in this together, and this is like one small piece at a time, and to remain hopeful about the changes that we can make and the things that are in our capacity to change. I do believe, I think there is some reality to this, that like to really address stigma to address stigma in the manner that I think we all want to see stigma addressed, it really requires a major cultural shift. And there are not that many examples of kind of major cultural shifts. We could talk about that later too, or talk about that offline. There are not many examples of this type of thing happening, but they do happen. But I think what's more realistic is kind of thinking about like the small piece that you can change, like the aspects that you can identify that are receptive to change, but to not get frustrated and not to get overwhelmed. So it's a slow process, but this is what I say a lot. It's a slow process, but quitting certainly won't speed things up. So what can we kind of do? Like, what is within our control to address stigma? One of the models that I relied upon over time is a modified social ecological model applied to stigma. So there's different ways that we've seen stigma interventions unfolding. One of which is in public policy, HIV criminalization laws, Presidential Advisory Council on HIV/AIDS, inclusion in national surveillance surveys and the impact of that. At the community and structural level, so different safety nets, availability of clinics, community cohesion, community advocacy, social and sexual networks, the impact that our family, friends, partners, etc. have on our values and beliefs, and of course the individual level, beliefs and attitudes and experiences that we hold. Now, most of my research does focus at the individual level and also is used to inform public policy. But this is just, of course, just examples of different levels of potential intervention. So some of the work that, some of the quantitative work that has specifically, I'm about to show you some of the quantitative work that has specifically led to the interventions that we are currently testing or that we've recently completed the testing of. One of the first studies that we did was focused on 153 Black sexual minority men in a longitudinal qualitative and quantitative study. And this assessment included 103 individuals who had recently tested STI positive and 50 individuals who had tested HIV positive. And we followed these individuals for a year. Excuse me just for a second. So what we did is we looked at among individuals who had recently tested positive for HIV or had recently tested positive for an STI, we looked at their access to healthcare and how that varied by their experiences of enacted stigma from healthcare providers. And what we found was that individuals who were inadequately engaged in healthcare were more likely to report a greater number of enacted experiences of enacted stigma from a healthcare provider. And we also see that same pattern when we look at anticipated stigma, individuals who are inadequately engaged in healthcare, particularly during this very critical time where we want individuals accessing treatment, they're more likely to report instances of anticipated stigma. So we know that these experiences of stigma, these enacted and internalized experiences of stigma have real effects on the likelihood that an individual will actually access healthcare. What's also very interesting that came from this research was how time unfolded. So what we found was that over the course of following individuals, for both groups who were inadequately engaged in care and adequately engaged in care, we saw that instances of stigma actually decreased over time. And this could be, there's a couple of reasons why that could be the case, but I think one of the most important things to acknowledge from this is that for a long time there was this, and I think it's still true to this day, that there's just this real strong priority for getting individuals who, in particular who have tested HIV positive, getting them into care as fast as possible. But when you kind of like slow down with that approach and kind of look at the data, it looks like there could also be like this processing effect of how people perceive experience of stigma, and that time could actually be healing, and that maybe, you know, from a biological standpoint, it makes sense to start people on HIV treatment as soon as possible. But it might be that from a social emotional sense, that some time is actually healing and potentially could result in better outcomes. Now, of course, I'm speculating there, but there does appear to be an important time effect in how individuals perceive experiences of stigma when they are recently diagnosed with HIV or an STI. Okay, so now talking about some specific interventions that we have developed. The first one we call Project Link. And what's kind of nice about giving a talk at this particular time point is that I'm going to tell you about Project Link and I'm going to tell you about Project Jumpstart. And both of those papers are recently under review. So we have, you know, in the past 6 months, yeah, we have finished up doing data analyses. So I have basically all of the final analyses complete. So it's good to be able to talk about a study with the final outcomes as opposed to things being in process. So Project Link, we specifically recruited Black sexually diverse men in and around the Atlanta metro area. Project Link was a 2x2 factorial design to test HIV, STI testing delivered online, delivered like this, like if I were to mail you an HIV and STI test kit and we did this via video chat, versus offering individuals in-office testing and a stigma-focused counseling, providing stigma-focused counseling versus providing a control online health information counseling arm. And so the spirit of Project Link was really to address stigma in 2 ways, one of which was to modify an environment. So change the system wherein stigma works. So what is, you know, the hypothesis was that if people are able to test for HIV in the comfort of their home, would that increase the likelihood of them showing to an HIV testing appointment? And that came from our qualitative work, where we found that there were a lot of concerns about who will see me. What if someone recognizes me? What if I don't like how I'm treated? Like, how can I leave an office? There were a lot of concerns in our qualitative data about how individuals would be treated once they showed up to a testing site. And so we said, well, what if we can control that environment? What if we can remove that environmental concern? What if we can transition that to a place where you now all of a sudden have quite a bit of control over the environment. And then we also potentially modified the experience of stigma by providing stigma-focused counseling for addressing concerns, for addressing emotional barriers to accessing HIV testing. So in the stigma-focused counseling, we assessed and discussed factors known to be drivers of HIV and STI stigma. We evaluated concerns around testing, of course, discussed prior instances of stigma related to healthcare, and promoted resiliency beliefs and positive adaptations. And a lot of that came from our qualitative, our formative qualitative work, where we found that basically what participants kind of were summarizing over and over again was that it's easy to talk about, and it's kind of like an easy and safe conversation to talk about logistical related barriers to accessing healthcare. But what's much more challenging is addressing the emotional concerns to how will that healthcare provider treat me? How will I respond under these different scenarios? What will I do if I feel like I've been mistreated? Those conversations were much more challenging. So that's the type of thing that we laid out in our stigma-focused counseling to address. So just kind of a brief summary of the outcomes. What we found was that offering testing appointments in person, offering testing appointments online with an HIV test counselor resulted in about a 10% increase in the likelihood of individuals actually showing to that test appointment. So that had a significant effect. And now, I should say that overall, we saw fairly high rates of HIV testing uptake. So around 70% of participants did show for their HIV and STI testing uptake, but we saw about a 10% increase in those show rates among individuals who were provided the counseling, who were provided HIV testing appointments at home. And definitely in the context, so I should actually say this too, that we were still collecting data when COVID lockdowns occurred. So we limited our evaluation time period to right before when COVID lockdowns occurred, because those lockdowns directly impacted the study, right? Because we were looking at in office versus at home, showing to HIV test appointments. So in the context of that, that was kind of like an added benefit that we were able to continue offering HIV testing for individuals who would do their appointments at home. But of course, we were not able to continue offering in-person testing once the governor of Georgia basically shut that down. We did not see a main effect of counseling, of the stigma counseling on showing to those HIV testing appointments. And I can talk about that too, because I think there's a few things to say on that, but we did see an increased likelihood of individuals under the age of 30 accessing PrEP, so going to an outside organization, an organization outside of a research site to access PrEP. So among individuals who received the stigma-focused counseling, they were more likely to report being a current PrEP user at study follow-ups. They were also more likely to report reduced rates of depression at study follow-ups too. And there's a very interesting area of literature focusing on stigma related to depression, how stigma counseling interventions can impact experiences of depression. And it's kind of a little bit of a spin-off area for the research I'm doing, looking at brief interventions as a way to address depression by helping people access healthcare. So there was a main effect of offering appointments at home. And in secondary outcomes, there was a main effect of offering the stigma-focused counseling. The other interesting thing that we found, and that that I have to speculate on, it's kind of open to interpretation, but it was really kind of an astonishing finding, was that individuals who were offered HIV testing online were significantly more likely to test positive for HIV. So for those in the online testing condition, 29 individuals ended up testing positive in that condition, and 17 individuals ended up testing positive in the in-office condition. Now, of course, individuals are randomized, so there's no reason to believe that there was a higher likelihood of individuals living with HIV unaware across conditions. One of the explanations of this is that, and this is something that I'd be happy to discuss with individuals because I'm interested in hearing what people think. So what we have found in other studies is that individuals who perceive themselves to be at risk for, or individuals who believe that it's likely that they'll test positive, that is correlated with testing positive. And so it's possible that individuals who were concerned about testing positive were more likely to show for those at-home appointments than individuals who were concerned about testing positive who were randomized to the in-office because of the level of control, going back to our qualitative work, because of the level of control that testing at home provides as opposed to being in office. That was something that was pretty universally established. I mean, we had some we did have some participants in the qualitative work that we did who said things like, no, I would much rather be in an office with somebody right there if I were to test preliminary positive for HIV. But I would say that was a minority perspective. Most individuals felt like they wanted, if they were concerned about testing HIV positive, they wanted that to happen in their bedroom at home, where they could control the environment, they could control the, potentially, I shouldn't say that all participants had a high level of control, but I would say most participants were able to test in their bedroom and had some control over like who was in that immediate environment. Anyway, but just really interesting findings around that. And then in the interest of time, because I see that's now 2:43 and I want to allow for some questions, I'm just going to quickly say a couple of things about another study that we've recently finished analyzing. We call this Project Jumpstart. And Project Jumpstart, we used a very similar stigma counseling approach to link individuals who didn't have any prior experience with PrEP use to PrEP service providers. There were 4 different arms. One arm was provided standard of care and direct referral to a PrEP provider. The next arm was provided what we call Jumpstart counseling, which was the stigma PrEP focused intervention counseling. The third arm was this Jumpstart counseling plus ongoing text messaging engagement to help support linkage to care. And then the fourth arm was this Jumpstart counseling plus phone calls, plus ongoing phone calls for about a 2-month time period to help support accessing PrEP engagement. And what we found with that is by virtue of simply providing a referral to PrEP care, 24% of individuals uptook PrEP in that condition. So not a huge percentage, but I think a respectable percentage, given that in our convenience samples, where we look at PrEP uptake among Black sexually diverse men in the South, we see at any given time about 5 to 10% of individuals will currently report PrEP use, and about 20% have a history of PrEP use. And so somewhat our PrEP use among our participants is somewhat on the low side. So to see 24% through referral alone accessing PrEP, we thought was a respectable percentage. And then as that intervention arm increases in intensity, we see a greater uptake of PrEP use. And this was within a 4-month time period. So when we provide that jumpstart counseling, we see a small increase to 29%. When we provide that jumpstart counseling plus the text messaging engagement, we see 34%. When we provide the jumpstart counseling plus phone call engagement, we see 37%. So we do see this kind of steady increase around this intervention arm intensity. And we also used biological confirmation of actually taking PrEP, and about half of the individuals who reported PrEP actually tested positive on the biological confirmation. The biological confirmation really only assesses PrEP use in the past 48 hours. So we do see some confirmation of that, but there's also some fairly serious limitations to using YourSure as a form of confirmation. And I'm just going to skip ahead just in the interest of time, because I see we're at 2:46. So that's an overview of the current interventions that we've recently finished up and have fairly recently put under review. We're in the process right now of doing a costing analysis of our interventions. It's a real priority of mine to keep interventions to design interventions that can be supported with currently available infrastructure. I mean, I just don't really see the point of developing interventions that cannot be pulled off outside of a research study. And so we are in the middle of costing data analyses, but I can say that our interventions are very cost effective. They are fairly low cost, and they can be developed, or they can be implemented with individuals who have HIV, prior HIV testing training and experience. We're also in the process of meeting with key stakeholders and sending out our intervention outcomes to service organizations across the country. And we currently are in year 2 of a study that's focused specifically looking at substance users and PrEP uptake and how substance use impacts PrEP PrEP engagement and retention. In Project Link and in Think Twice, which was a study that preceded Project Link, we observed among our substance users about double the likelihood of seroconversion over the course of a year. So we're in the process of developing stigma-focused interventions to address both emotional barriers to accessing drug treatment and also accessing HIV prevention services at the same time. I'd just like to remind people that our fight isn't over, and that we continue to be engaged in HIV prevention and treatment research. And that is it. So thank you, y'all.
That was really great. Thank you so much.
Absolutely. Happy to be, and I think I shut off my screen, I think. Any questions on anything?
Hi, Lisa, this is Miley. I have a question for you as an expert. I think your work is very interesting and fascinating, but I have another question I'd just kind of like to hear your perspective on around stigma. So as you might be aware, the advent of our long-acting injectable HIV medications has seemed to produce a decrease in internalized stigma in people who are using them. So there is certainly a signal that there's an aspect beyond just convenience of coming in twice a month that seems to be impacting, a person's experience living with HIV. I've, anecdotally, some of my patients that have transitioned to the long-acting injectable have told me things like, it's wonderful. I feel like I've been cured. And I think a lot of that has to do, so my hypothesis, and I've written a grant that didn't get funded to try to evaluate this, but I'm curious to hear your perspective, is that, they no longer have to think about the day-to-day, like every day that they have HIV, because the pill is a daily reminder that they're living with HIV. And even folks that have been living with it for a long time can still sometimes have a lot of self-regret and self-dislike related to that. I mean, I've had patients come to me and saying, this is a great clinic, but I hate coming here because I'm healthy and I'm reminded I'm sick when I come here. And so but my thought is, is the stigma actually going away, or is this just avoidant behavior that in the long run is not going to be ultimately helpful for these folks because they're not actually addressing, their internalized stigma? I mean, that's, I don't know. I mean, I would love to hear what you think about that.
Yeah, no, it's a super good question. It's a really good question. And it's really interesting. And it's something that I could probably talk to you for hours about. So I'm gonna try to be succinct, but it probably won't happen. So really, please feel free to email me because I would love to talk about this more. There's just so many things to unwrap here. One of the things that we've been hearing from our participants on this topic, well, one, we don't see a lot of it. We actually, in our current study of PrEP users, so this study started in December, so that's a bit prior to the approval, but with our most recent participants post-approval, the long-acting injectable, we see the uptake to be very low, but of course that can certainly change. And we do mention it with all of our participants that this is now available. One of the things that we hear is that participants will say things like, a lot of our participants are not using PrEP as prescribed. They're not taking it daily. Yeah. And so, that's always like a tricky area for us because it's prescribed as a daily medication. But of course, we're aware of intermittent dosing. I would say that the vast majority of our participants say things like, I really don't have a lot of sex. I really don't have a lot of partners. And I just want to use it like once a month or like once every other month when I do have a partner. And so in the context of the injectables, I think that's one of the reasons why we don't have a big uptake. But again, like it needs time. I mean, any sort of like advancement in treatment needs time to kind of pick up speed. So that could be a big feature of it. But I do think that for individuals who just, they have a more active sex life, I could absolutely see things like, I don't want to be reminded of this pill every day. And this is a great option for me because of that. I think one thing that's not quite clear to me with it is so it's every other month showing up to a clinic for an injection. And for some of our participants, they might get a prescription for PrEP and it might last them a year, or they might be able to refill it. And again, this kind of falls into a blurry area. They might be refilling their PrEP prescription without picking up additional labs. And so we've heard that too, that they're not taking it daily, and sometimes they're able to refill it without lab work. Of course, we don't want participants doing that, but again, I'm just kind of, yeah, and there's a comment about insurance access. Absolutely. So it's I think ultimately, I think what it is about is it's about having options, like having options to potentially for each individual to address their own personal experiences and concerns about stigma. It's really how, from the very beginning, how I described and proposed the online HIV testing option to community partners, because I mean, that was like, I originally proposed this to community partners like 8 years ago. Because obviously, it just takes so many years to get a grant. And then like we actually tested the whole grant. So it was really like 8 years ago. So it was before, I mean, now there's different online companies that are, online telemedicine companies that have been, that regularly offer it. So the way to kind of get community providers on board was saying, like, it's just think of it as an option. We're not trying to replace in-person testing. It's just an option for people who might be more comfortable. And I think the same is probably true with the long-acting injectables. Like, it's an additional option. And that option in this context could be very, very meaningful for someone who's concerned about stigma, for someone who does not want anyone in their family knowing that they're taking any medication related to HIV. Like, this could be an excellent option. So, yeah, that's probably a really long, but I just think it's such an important area because it's like clearly it's
the
clearly,
future. I mean, it's where
yeah,
we're going.
yeah,
It's ultimately, I
yeah,
think, going to be everybody once we have more options.
absolutely,
So it is
yeah,
where we're going for sure, but yeah.
yeah,
I had so many, all these stories as you were speaking just came into my head specifically about like when our folks go to the ER
yeah,
and how they get treated there just because they have an HIV diagnosis on their medical record, and how they subsequently never want to go to the ER. And, it's why people come into our clinic with active chest pain, because they don't want to go to the ER
yeah,
because of these bad experiences. And how do we improve that from a provider standpoint? But yeah, I
yeah,
really appreciated your thoughts and your comments about, how we are asking the questions, do we really need to be spinning this in such a negative way? I think that's a
yeah,
really interesting way to look at things. But then we have to go and validate positively worded questionnaires,
right.
which also takes time and money and all that stuff.
No, it's true. And so much of the research is deficits based. It's something that I know I've contributed to that, and I don't like knowing that. But a lot, first starting out this research, it was like that was the mindset that we're coming from, like a deficits based perspective, and flipping those things to an assets based and a strengths based perspective. There are only so many tools for that because these things are like going to develop and research moves very slowly. But I think it's very meaningful in the context of stigma to really consider those things. And just like you're saying, like positive sexual health, positive sexuality, positive well-being around sexual health. These are concepts that like, they feel like, I know a lot of researchers have been talking about these things for a long time, but in many ways it feels like these concepts are in their infancy when it comes to healthcare and education and so on and so forth. And it just takes time. It's goes back to my it's like one small piece of the puzzle, and remaining hopeful and not getting frustrated with the area. But I'm really happy to talk more on that topic. I think I agree it's the future, and I think those long-acting injectables will only get better in their administration. And I would imagine like there'll be a longer time period and more of like a set it and forget it, if you will, kind of like what we've seen in birth control approach. And so and I can say about that topic is we see more conspiracy-esque beliefs around our long-acting injectable, like and I'm cautious about using the word conspiracy because that's loaded, and it kind of invalidates people's real fears about injecting themselves with something, and so I don't mean to do that, but it's just the word that's available. But I do think conspiracy-esque beliefs around long-acting injectables is something that really have to pay particular attention to. And that,
especially in populations that have been purposefully harmed by the medical
absolutely,
community.
absolutely, absolutely. We have absolutely had participants who will talk about family members who were harm in medical research, and that's a very real experience. And so that's why I say I use that word with caution. I know that's what we see in the literature, but that mistrust, it's mistrust and distrust. And those are very real experiences. So yeah, it's very interesting, and there's a lot of work that can be done there. Anything else? Any other questions? Well, I'm happy if anyone messages me outside of this, I'm happy to respond. And yeah, that'd be great.
Thank you.
Thank you.